Hi, I'm Dr. Amy Krie. I'm a breast medical oncologist at the Allina Health Cancer Center in Minneapolis, Minnesota, here to help moderate today.
My name is Dr. Mabel Mardones. I'm a breast medical oncologist with Rocky Mountain Cancer Center's Sarah Cannon Research Institute, Denver, Colorado.
Hello, my name is Ann O'Day, and I'm a breast medical oncologist at the University of Kansas Cancer Center in Kansas City.
And Mabel, thanks for joining me today. I'm so excited you guys could join us and talk about DB09 and how fast the landscape of HER2 positive metastatic disease is changing. Just going back historically now, 2012, some of us were there. CLEOPATRA gets presented. That's the addition of pertuzumab to the taxane and Herceptin, which was the standard at that time. And of course, we saw an increase in median progression-free survival. We saw an overall survival almost reaching 5 years. And can you talk to me a little bit about that regimen, walk me through it,
Yes.
and how you think that's really sort of changed the landscape over the last 10 years?
Yes, for sure. I remember being at that presentation and getting goosebumps and standing ovation, and things like that don't happen very often in breast oncology. And so certainly that was a pivotal time for us. And I think that's why it's even more exciting now that we're talking about the future and moving beyond that. But certainly at that time, CLEOPATRA established the standard of care with the addition of pertuzumab. So dual anti-HER2 therapy in combination with the taxane. We get a median progression-free survival of about 18.9 months with CLEOPATRA, which was basically a doubling from what was the standard of care without pertuzumab. So that really has been the mainstay of treatment for us over the past 10 years. And we all certainly have patients in our own practices that have done exceptionally well on that regimen. We also have patients that have not done quite as well. And so certainly we have opportunity to look for improvement.
And Mabel, can you touch on maybe some of those unmet needs with the CLEOPATRA regimen?
Yeah. So I think there's questions on both ends, as you mentioned. One is that about 16% of those patients continue on HP. And the idea is we have long-term survivors, dare we say, even cured patients. But is there an opportunity at all to stop any trastuzumab or pertuzumab-based therapy? I don't think any one of us are feeling comfortable that that's the case. The second opportunity is in those patients who we know, and it's around 15% of those patients who actually do not do well with the regimen and do progress early or through that regimen. I think those opportunities are there as well.
And I always think about, the blood-brain barrier, right?
Absolutely.
And the CNS. And a lot of these patients are going to recur in the CNS. And are there opportunities there? And can you talk about, obviously, the goal of moving sort of to an ADC, sort of non-chemotherapy? What were some of the challenges with the taxanes?
Certainly, I think what we see when we're using a CLEOPATRA-like regimen is standard taxane chemotherapy. Depending on whether these patients were treated in the curative setting, they may have residual toxicity. Persistent and maybe permanent neuropathy is kind of the one that seems to be dose limiting for us. Not to mention the impact on fatigue and quality of life, hair loss, things that really matter to patients that are continuing to try to live their life. So I think that's a huge thing. And I think the other thing that we really get concerned about in this population is, when patients recur, is how do they recur? Because if they recur in the brain, if they recur in the central nervous system, there's really nothing more life-altering for that patient population. You talk about whether they need whole brain or SRS or, whatever that looks like for them. It's really catastrophic in terms of their quality of life. Yeah, and it's a huge fear.
Yeah. Cancers in my brain is obviously something nobody wants to certainly hear. Well, let's jump forward. ASCO 2025, we saw DB09. So that was our first look at that data. We certainly saw the two arms, the trastuzumab deruxtecan pertuzumab arm compared to the standard of care CLEOPATRA arm. And certainly that amazing median progression-free survival over 40 months there. Talk me through that trial, maybe what your initial thoughts were.
Yeah, so I will tell you I thought it was incredibly impactful to see a hazard ratio in the first-line setting after a median follow-up of only 29 months, little over 2 years, to see that hazard ratio of 0.56. Very, very impressive. I think, as you mentioned, there were 3 arms to that study. Yeah. So I think we still await the results about, is T-DXd alone certainly a reasonable option? We do know that pertuzumab does add toxicity, and I think it's incredible also to have seen that not only overall response rates were improved, but complete responses were also improved nearly 14%.
It was like,
So again, that's a real important outcome because the depth of a response in the first line setting may correlate with setting up the stage for what could be a much more impressive overall survival than we saw with CLEOPATRA. I think that's what we're all hoping to see, especially as we start to sequence more and more options.
Dare we say cure for any of these patients, of course, is the exciting thing. And how did you describe the shift to your colleagues?
I think, when I first heard the number, we sort of all anticipated it was going to be positive. We've seen what T-DXd has been able to do, and it's really been a game changer, drug for us. So we all sort of anticipated it was going to be positive. When I first heard the number, 40 months, I literally said, did you say 40?
Yeah.
Like 40. I think that is just, just to think about talking about that with patients is really amazing. And as you mentioned, about 15% of patients, maybe 1 out of every 6 or so, getting a complete response with metastatic disease. That to me is just, that is so very exciting. And
we were so excited about CLEOPATRA.
Right.
And then the magnitude of that benefit.
Right, absolutely. And to think about that, some of these patients, might actually be cured, is really exciting, obviously.
So let's move into the clinic. It's Monday morning, your first patient's coming in with this option. Are you starting all patients on DB09? Which patients, I think, are you moving to DB09 now, given this data?
So I think there's still a framework in my mind. I don't think that I'm collectively offering it to all, but I am thinking through, what was their first treatment like? How quickly did they progress? After, are they a de novo patient? How much visceral disease do they have? Do they have oligometastatic disease? Do they have 2 or 3 bone mets only? I take into consideration their ER and PR positivity, negativity into the equation. Certainly, brain metastases is very important if they do have it up front. I think that I am going to be favoring the T-DXd pertuzumab regimen on those patients, as we've seen a collective amount of data supporting T-DXd and its impact in central nervous system control. So those are all things that I will be taken into consideration. I think I will lean towards the T-DXd pertuzumab, but really in a group in which the CLEOPATRA still fits in a suiting. I think, like all of us think through, is comorbidities and performance status too. I think that all has to be taken into consideration as I think through taxane versus T-DXd.
And Anne, you take care of so many breast cancer patients. I know do a lot of second opinions at your practice. Tell me about the patient coming in. How are you going to have this discussion with that patient?
I think we're absolutely obligated. Anytime we have something with, median progression-free survival of 40 months, a 15% chance for a complete response, we absolutely owe it to our patients to discuss that option with them. I think absolutely looking at how that patient is coming to us. Do they already have neuropathy? Does the patient have really significant or even moderate diabetes to where incorporating steroids with the taxane is difficult for them? These are all considerations. I know it seems trivial, but hair loss, is many of these patients may be either de novo or they may have had a 4 or 5, 6 year treatment-free interval. They've just gotten their hair back. They're very excited to keep that. And so that's, something that we have to discuss as well. And I think when we're talking about, quality of life for them, it's really a discussion about what does life look like on T-DXd compared to a taxane, trastuzumab, and pertuzumab, and what are the pros and cons of that. And I think for me, it's talking with them about what gives us the best chance to get the deepest response, right, initially.
And that's what I often hear. I hear, use your best drugs first. And I've also seen data presented in HER2 positive disease that maybe, a third to a fourth of patients who get first-line therapy might not go on to get second-line therapy. So talk a little bit about that philosophy, I guess, of using sort of the most effective drug first.
I think for us, definitely in the HER2 positive space, is when we know there's a propensity for central nervous system metastasis. I think this is the place where using that first drug first absolutely makes sense, or using the most effective drug first is absolutely what makes the most sense, what's going to give us the deepest, most durable response. And then certainly weighing that with quality of life. I absolutely have seen those data sets as well, that we might lose, a significant number of patients that go on to get second line. And I think between second line and third line, we lose about half of patients that aren't able to go on for whatever reason, whether it's rapid progression of brain metastasis or deterioration in performance status, whatever that is. So to think about a patient that might miss out on the opportunity to receive T-DXd with these kinds of progression-free survivals, hazard ratios, chance for a CR, to me, I'm not willing to take that gamble, really. Right. And so for the majority of patients, we're going to recommend this in the first line.
So definitely shared decision-making, but a lot of reasons to think this is very hopeful. I wanted to talk a little bit about, your clinical practices. We all have experience now with Enhertu. Tell me, do you have patients on it for a long time? How do they tolerate it? Tell me your experience.
So I think in both settings, whether it's HER2 positive or HER2 low ER positive, in other settings, we've used Enhertu. And I think there's probably three things that come to mind for toxicities for me. One of them is going to be that early nausea, vomiting that can be a very real issue, right? It's a highly emetogenic protocol. I think having a 3-drug regimen, at least 4 to prophylax patients, is important. I think olanzapine is quite helpful in my practice to also manage that particular nausea, but I also don't find it to be rate limiting for the long haul. I feel that if we get really good control of that issue up front, that we can really set the stage for success. Issue number 2 is fatigue. I think it's a real issue. We know that it's still a cytotoxic payload at the end of the day. And so when we've gotten the best type of response and people are on long-term in HER2, it's important to consider the aspects of their life into their treatment. So taking a trip, events, it may not be that you'll give them dosing every 3 weeks, at least for the long haul, right? And then cytopenias, neutropenia could be another thing. Obviously, you spoke on alopecia. Alopecia seems to be a little different than traditional cytotoxic chemotherapy. It's much slower. I don't know your collective experiences with cold capping, but I have certainly had those patients who have been very motivated to use cold capping with Enhertu as well.
I did want to talk about, one strategy I've used in clinic sometimes is a dose reduction. Were there dose reductions on the trial? Is that a good strategy for keeping patients on drug?
We have had experience doing that. And those patients that I have, going on 2+ years of T-DXd certainly get to a point where, particularly if they've achieved a complete response and, they're doing really well, we want to look for opportunities to improve their quality of life. Certainly, we're trying to help these patients live longer, but we want them to be able to live better. So making sure we're doing good internal medicine, checking thyroid functions, checking vitamin D levels, doing all the things we can to help maximize their quality of life in terms of their energy level. But using dose reductions is something that we certainly do early on. I think in the DESTINY-Breast9 trial, it was a little more than a third of the patients that had a dose reduction. So we can feel comfortable telling our patients this, about a third of the patients in the trial had a dose reduction and they still had that significant efficacy. So I think if you dose reduce based on your patient's symptoms, you should feel quite comfortable with that.
Yeah, and I think that's something doctors should realize. And I've certainly seen in my practice in terms of the fatigue, it often does respond to that dose reduction sometimes. So definitely something important to put out there. And also so patients don't feel disappointed if they have to lower dose, because patients want to, of course, get the best treatment they can. So, well, let's move on and talk a little bit about pneumonitis. What did we see with pneumonitis on DB09? Mild, how do you manage that? Let's talk about that.
Yeah, we saw about 12% of patients, which is very consistent with what we've seen from all of the Destiny breast trials. So about 12% incidence. The most common grade is 2. And, we have to remember when we're talking about pneumonitis that 2 means mild symptoms. Remember, 1 is completely asymptomatic. It's just radiographic pneumonitis. The patient isn't going to even be aware. It's something that we see on our scans. So 2 is mild symptoms. And that was the most common incidence and has been in the more recent or contemporary Destiny breast trials. So I think that's something when you have this education and, shared decision making with your patients, you're really emphasizing the importance for them to tell you, are you feeling more short of breath? Have you developed a cough? It is critically important that you let me know about this if this does develop, especially when we're talking about having patients on these drugs for months and maybe even years. Yeah.
And the pneumonitis, is that always early on? Can we see that later on? Can you talk a little bit about that?
I think many of the trials have supported this idea that within the first year that can be more common, but I think we've all had patients who have had pneumonitis late, even up to 2 years post. So I don't think there is ever a scenario in my practice, and I think you ought to agree, that we would relax surrounding the monitoring and the
kind of have some vigilance there.
Vigilance
ongoing.
the whole time. I think the other thing I want to mention is that although, to your point, 12% did have grade 1 and 2, there were 2 deaths in the study related to ILD. And I do think that at this particular pneumonitis, ILD is a very different scenario than your IO-related pneumonitis, CDK pneumonitis, or other drugs that we're used to. It is obviously a very serious issue when not detected, can lead to compromise, right? So
you mentioned the scenario, Anne, about the patient who doesn't have clinical symptoms where you're just seeing it maybe on their staging study. How do you manage that patient? Do you re-challenge the drug in that situation?
So I think the way they handled it in the protocol, and I tend to follow exactly how it's been done in the Destiny breast trials. So if, I typically repeat a scan at just under 4 weeks. If it is completely resolved, so radiographically completely resolved, we go right back on at the same dose, assuming the patient has been tolerating it otherwise very well. If it takes longer than 4 weeks, if it takes 6 weeks, 8 weeks to completely resolve, then when it does resolve, we do drop a dose level and careful monitoring at that point. Certainly, if patients develop symptoms, very low threshold to start steroids, very mild symptoms, we start somewhere in like 0.5 mg per kg. If it's a more severe symptom, a milligram per kilogram, watching those patients very, very carefully. I tend to get pulmonary involved right away. We're typically bronching these people and certainly ruling out other, concomitant infections and other causes of pneumonitis. Absolutely. Yeah.
Can you talk about the patient with symptoms? Do you ever re-challenge in that setting?
Yeah. I will tell you I have, but I think it has been the exceptional patient, like Anne described, that was started on steroids and recovered very quickly.
So minimally symptomatic situation. I know we saw some data at ASCO supporting that as a possibility.
Quick response to steroids. Right. Yeah, those are the patients I would consider it.
Perfect. Thanks for going over that. Anything else on the ILD pneumonitis that we need to mention?
I think the frequency of scans comes up often. I think the protocols were very stringent about every 8 weeks. I think sometimes in clinical practice, that's not always possible. So I think about every 12 weeks in my practice is not unreasonable.
And talk to me about, is there a patient profile that you think might be a little bit higher risk for ILD? What some of those risk factors might be?
I think so far the data really, the only thing that's kind of emerged is chronic kidney disease, which no one can really, at least no one I've spoken with has really been able to explain the pathophysiology behind that. But for whatever reason, patients that have chronic kidney disease seem to have a higher propensity to develop ILD. So those are the patients I do try really hard to make sure to do their scans at like 6 to 8 weeks and really try to make sure to watch those patients carefully. And I do think, to your point, I know you practice in Colorado, I practice in Kansas, I practice in a rural state. I have patients that come, drive 4 to 6 hours to come to see us. Those patients aren't going to always be able to come every 6 to 8 weeks and get a scan. And so that's part of the decision making, right? That's part of deciding which patients are appropriate for T-DXd. And patients need to understand how important the monitoring is, and they have to really buy into that and be able to do that. If they're not, then that's a patient I might feel more inclined to do kind of standard CLEOPATRA, honestly.
Regimen.
Yeah.
Mabel, any other risk factors you think of?
Although by no means a risk factor, it just makes it more challenging from a clinical standpoint to detect issues would be comorbidities, right? If they're already on oxygen and if they have other pulmonary or cardiac issues, just makes it a bit more challenging. I'm going to probably be watching those patients more.
It wouldn't not do it. Yeah. Correct. Just wouldn't want to watch them very carefully. Correct. Yeah. I remember the very first patient I started on T-DXd when it was first approved in like third line. Yeah. And then she had bilateral pleural effusions, was on 2 liters of oxygen, all because of her disease. And we sort of had the discussion, you're my first patient that I'm going to be prescribing this. It's giving me a little bit of anxiety. I want to make sure that you understand how important it is to let me know about any change at all. Luckily, she developed an amazing response, and so her hypoxic respiratory failure actually improved because it was disease related. So I don't want those patients to miss out on T-DXd, but certainly we do have to watch them really carefully.
So I hear a lot about, weighing AEs and toxicities with efficacy. Do patients differ in that? How do you sort of weigh that out?
For the individual patient, I think they're going to be asking questions about, the alopecia, the neuropathy, the nausea, vomiting. But to be quite honest with you, I think, like you said, we owe it to our patients to give them the best option. Patients are willing to tolerate more if we explain the tremendous efficacy that they're going to be deriving and what the stage is. I think it's also important to mention that in DB09, as we all know, it was continuous T-DXd pertuzumab exposure, and that the average time those patients were on therapy was somewhere between 2.5, 3.5 years. So I think there is a con there that we have to discuss with patients, right? They didn't go on to a maintenance strategy like CLEOPATRA, and I think that that's something we have to also take into consideration.
Absolutely. And we're hopeful that we might see things like that emerge in the future, especially when we look at these patients and the depth of response, these patients achieving a CR, can we follow those patients with ctDNA or some other genomic predictor to tell us which are the patients that are likely to get those long-term durable responses, and maybe would be just fine with a maintenance strategy with HP alone or whatever that looks like for that particular patient. And I think that's what we're really excited as kind of the next step to see if there are patients that becomes a viable option for in the future.
I think that's so exciting, individualizing therapy for HER2 positive disease in the metastatic setting, that we have all these options. Are there situations where you sort of this de-escalation strategy that you mentioned? So certainly CLEOPATRA, we gave on average, 6 to 8 cycles of chemotherapy and then sort of dropped back to the Herceptin and pertuzumab. Are there certain patients where you might foresee doing a similar strategy with DB09?
I've actually done that in my practice already with a very extensive discussion with the patient that there's absolutely no data at this time to support that, right? But I had a young patient in her 40s. She's single, working full time, trying to be, very active. And she had been on T-DXd for 2 years. A solitary liver and a solitary bone metastasis, both biopsied, so both proven to be metastatic disease, with complete response by imaging. And just with the fatigue and, everything kind of weighing on her, we had the discussion and we made the decision together we did an MRI of her brain. We made sure we didn't see any, CNS disease. She has a CR. She has for more than 12 months, and that's been maintained. And so we are doing trastuzumab maintenance, and we're watching her very carefully with scans. And she's the kind of patient that I know will tell me if she were to develop any sign or symptom suggestive of progressive disease. And I also trust that she's going to be very compliant with her surveillance scans. Certainly no data, but these are strategies that might make this a more viable option for a majority of patients in the future.
I had a similar patient, Anne, she was young, wasn't tolerating things well. So the first thing we did is sort of drop the pertuzumab. She did a little better, but still was struggling. And after 8 cycles, she had a radiographic complete response. And actually we looked at molecularly, had a complete response as well, and are sort of opting to de-escalate and follow her too. So there's a lot of now shared decision-making in our clinics. It takes a long time, but I think it's great to have so many options.
I think we can feel supported in that strategy too, though we don't have the results at all. But the Demeter study is a phase 2 study looking at exactly that strategy. Can we do T-DXd up front for 6 to 8 cycles and then move on to a maintenance strategy? And I think as complicated as maintenance is now, especially with the next discussions we're going to have surrounding patina and HER2 CLEOPATRA, I think we can feel that that's a relatively good strategy, but I think we ultimately need the data to support it.
So more individualization,
Yes.
Just this morning seeing the HER2 CLEOPATRA-5 data. Tell me your thoughts on that, Mabel. When you saw the addition of tucatinib to maintenance, what did they find?
So obviously this is post induction with your CLEOPATRA regimen. That's important to know. And they did take both the ER positive and the ER positive group of patients and randomized them to receive TRAS-based therapy with or without tucatinib. And what they saw in their first analyses is an improvement of about 25 months with the tucatinib arm versus roughly around 16 months. But when you looked at the ER positive and the ER negative group, there was a slightly higher numerical benefit for the ER negative group, a delta of about 12 months, as opposed to nearly 7 months in the ER positive group.
And my understanding is not all the ER positive patients got endocrine therapy.
That is correct, about half.
About half. So sort of factoring that into, and speaking of patina, also a really good progression-free survival on the patina. And can you talk us through the patina trial a little bit?
So I think that also is something that we have to, when we're talking about individualizing therapy, is certainly one of the things that Mabel mentioned is looking at the degree of hormone positivity. is this a patient that has high expression of estrogen receptor, progesterone receptor, and even clinically is behaving a little bit more like a luminal cancer, right? Do they have like limited bone metastasis, long disease-free interval, limited burden of disease, lack of visceral disease, lack of brain mets? If it's that type of a patient, then patina might be a really good strategy. So in patina, they randomize patients after a CLEOPATRA-like induction standard of care to have the addition of palbociclib at the standard approved dose, 3 weeks on, 1 week off, as kind of a maintenance strategy, or placebo. And they saw that the patients that received the palbociclib actually had quite durable responses. I've spoken with Dr. Rugo about this. She was one of the main investigators, and she says she has patients still on, that are doing very, very well. So for those patients with hormone receptor positive disease, that can be a very viable strategy. We all know how well palbo is tolerated. The monitoring is relatively easy. And so that might be a good option for those patients that we feel like are more of a luminal type of a phenotype.
What this underscores for me is that we have these amazingly targeted drugs that we're now adding in, and it's becoming complicated. But I think we're ultimately forgetting that, at least in the triple positive group, the endocrine therapy is critically important, right? When you look back at CLEOPATRA, for example, it was not mandated that people have endocrine therapy in that group. In DB09, we just very low utilization of endocrine therapy in the ER positive group, only about 13%. And then as we now go on to these post-induction maintenance, a lot of heterogeneity there. So I think that underscores the importance of endocrine therapy.
Yeah,
Simple, right? Simple,
I think
but
people are
important.
so focused on the HER2 aspect of this and sort of forget that crosstalk with the estrogen
But
receptor.
I think patina kind of re-emphasized to us,
sure.
How important that is, and that is a viable, strategy for patients. So whether you're going to do a DB9 strategy, whether you're going to do a HER2 Climb 05 type of maintenance strategy with the addition of tucatinib, whether you're going to do a patina strategy, the endocrine therapy should not be forgotten. Absolutely critically important. And that goes along with, for our premenopausal patients, making sure their ovaries are adequately suppressed. I see this happen a lot. I do second opinions where a patient's been put on a CLEOPATRA-like regimen, and now they're 12 months out from their chemotherapy. They're just on HP, and no one's bothered to check their estradiol levels. And turns out they've come out of their chemotherapy-induced amenorrhea. And so not only is not receiving endocrine therapy, but also not receiving adequate ovarian function suppression as well. So those are the nuances that I think we have to really kind of clean up so that we're fighting for those, 1 to 0.5 percentage points for every single patient.
And to add to that, in these women above the age of 45 to 50, right, when they've gotten their chemotherapy, you just think, I can relax about their ovarian function. They're probably going to be permanently in menopause. That's not always true. And I do think that's a fabulous point you brought up, that we should not forget. Let's check. We have to keep checking.
And we all have cases where we've seen a
Yes.
second opinion. A woman's on an AI. We check the estradiol
Through the roof.
It's through the
Yeah.
roof. So great point. Great point to bring up. So yeah, talk me through some strategies then. I mean, do you envision sort of an induction and then a tailored approach? Obviously, it's decisions we're going to have to make in the clinic in the next year, and how will we make those?
Yeah, the way I'm thinking through things at this moment is I'm going to have that whole nuanced discussion surrounding the lack of data supporting just a finite amount of T-DXd. So I think that if I've not gotten a depth of response that I needed, if it was a patient who was, very symptomatic, progressed very early after their adjuvant therapy, those are not going to be patients I'm going to be comfortable necessarily transitioning to this finite induction and then a maintenance.
Okay.
Whereas if I have a patient who's de novo, right? De novo responded beautifully back to your point, their ctDNA cleared very early, maybe negative past 8 cycles, then I'm going to have those conversations. And the way I see this is a little bit of ER positive, ER negative route for me. For the ER positive group, I think I'm going to align with patina regimen. For the ER negative group, I'll probably do tucatinib, with an exception there being those who have brain metastases.
Yeah.
If it's someone with brain metastases up front, then it's someone I'm going to transition first T-DXd, of course, the DB09 regimen, and then tucatinib.
I think I'm not sure that I have the courage to stop. I do have a young patient right now I'm thinking about that's on T-DXd, the DB9 regimen, and she's on T-DXd, pertuzumab, doing well. does have a solitary brain met that's been radiated, and we just sort of forge ahead. I don't know that I have the courage to stop. I mean, maybe we should.
Maybe it's a timing issue as well.
Yeah.
Right?
And a tolerability issue. If she's tolerating it well, she's not progressing in the brain.
Right. The fear is, you feel like you have a little bit of room, with your other visceral disease, even if you get a new met in the liver or something, we can deal with that. A new brain met, a leptomeningeal disease, that's not something that we can easily reverse. And so I guess I'm always so afraid to think about those patients. So I hope in the future there'll be some guidance for us about those patients with low volume brain metastasis that maybe a maintenance strategy is appropriate.
So we've talked about, we've all obviously got patients already on DB09 regimens in the clinic today. What happens when and if, hopefully a long time from now, but what happens when these patients progress? Where do we go?
Yeah, it's the age-old question of sequencing and how complex that can be. But I think at this point, for me, if someone's progressed on the DB09 protocol, then I'm going to lean on the HER2 climb protocol, the triplet at that point. I think we shouldn't forget Kadcyla is a very active agent in HER2 positive amplified disease as well, and obviously the menu of chemotherapy options that follows. Obviously, if a clinical trial is available to me, I will always prefer that given that there are so many other standard options available. I have zanidatamab available in my center, and so that's something that I'm going to lean on.
Yeah, a really important area for clinical trials, obviously, going forward.
I agree with you. I tend to favor a strategy of, ADC followed by a TKI, followed by an ADC, followed by a TKI. For whatever reason, that seems to make sense to me, just alternating the mechanism of action. Although I think we're going to have to look, the standard of care is evolving so rapidly. We're not going to have large phase 3 trials to answer these questions about sequencing. We're going to have to rely on smaller studies, real world data. And I think that's something we all need to get comfortable with as oncologists. I hear all the time when I'm talking to people who've sent second opinions and they say, well, there's no phase 3 trial looking at this after that. And I'm said, and there's never going to be. And so we're in this era where we really have to be looking at all the tools that we have and making the best use of those for the patients. And we're going to have to look at the best data that we have. And it might not always be a phase 3 randomized placebo-controlled trial looking at sequencing. It's just not feasible.
Now, what do you say to the person who thinks about sort of holding back DB09 for the second line? Sometimes I hear that strategy. What would your thoughts be on that?
I think you talked about 20 to 30% of patients will not access second line options at all. I think that's very sobering. And I think that's where one of my strategies would be, lean on the best tools up front. Honestly.
Absolutely. And then just that fear that, that first place of progression might be their CNS. And that's not something that's easy to sort of regain or get control of once we've lost it. And even the treatments that we employ to sort of obtain control of CNS disease, no patient is ever the same after they have brain radiation. I mean, they will tell you, their families will tell you, they are not the same. And so even though we might be able to sort of, do some SRS or do something to sort of, placate that disease for a period of time, I don't think we can fully understand the magnitude that has on quality of life for patients. We also have to think about the issue of radiation necrosis surrounding the ADCs and timing of radiation therapy. That's becoming an area that we're becoming increasingly aware of. And we want to make sure I have one patient right now that is completely without evidence of disease in the CNS or otherwise, and all of her symptoms are being completely driven by the degree of radiation necrosis that she has, which is extremely difficult to treat.
So let's think about, you want to say something to a physician, at home in the community who sort of sees everything as they're starting to incorporate DB09. What is one thing you would say to them?
Magnitude of gain in PFS, the complete response rates achieved with this regimen, the prevention of CNS metastases cannot be underscored and are hard to unsee. And I think that is the reason why DB09 will now be the standard of care for most patients.
And any other thoughts?
I think just to expand on that, absolutely the efficacy is there. It speaks for itself. 40 months is 40. That's unheard of. I think it's helping them feel comfortable with the monitoring, managing the toxicity, being willing to employ dose reductions to keep patients going, early utilization of additional antiemetics such as olanzapine. Those are all, I think, the clinical pearls that allow this drug to be very, very tolerable for the vast majority of patients.
So again, really excited. DB09 coming in the first line metastatic breast cancer setting. Thanks for being with me today, and enjoy the rest of San Antonio.
Thank you for having us.